Hi, this is John Kanellopoulos, clinical professor of ophthalmology at NYU Medical School in New York City, New York, and medical director here in the Laser Vision Ambulatory Surgery Center in Athens, Greece. We're going to go and see a very sad story, and I never like to criticize colleagues, but this is a 22-year-old young lady who, while showering in London, of all places in the world, with her contact lenses on, contracted acanthamoeba. And this is the OCTs. This is from the summer of 23. She went to one of the ivory towers of ophthalmology in London and was recommended a single therapy with PHMB as treatment with acanthamoeba. I saw her shortly after, so this is my picture, a week after her infection, and I definitely recommended double therapy to also include Broline. As we know, PHMB may not be effective both for the organisms of acanthamoeba and the cysts. Of course, she opted to follow the advice of the reference center. And unfortunately, we were correct. She had a reinfection. She opted to go to double therapy 2 months later. This is her in January of this year. So this is like 7 months ago, where now we have a more spread, diffuse scarring. She has been on double therapy, PHMB and Broline for several months. And again, a dilemma. We recommended at this point to start topical corticosteroids because the token here is that we also want to keep a clear cornea. This is a spot-on center infection, a spot-on center scar. The vision here is 2200. Best corrected. And again, a lot of resistance. I'm not criticizing, but many colleagues fear, and it's reasonable that the corticosteroid treatment may mask the symptoms of a prolonged or a reignition of the cysts to an active acanthamoeba infection. And this is where we are now. We're using dexamethasone preservative-free for 3 months. Our visual acuity has improved from 2200 to 2070. And the recommendation from London is to have a transplant. Now we beg to differ because we feel that in this cornea, and we're seeing here the epithelial map, we're seeing here the indeed dense scarring, we cannot ignore the irregularity that the scarring has created to the reflection topography. And we prefer reflection topography here to sign fluke because obviously the haze within the cornea will mask the imaging accuracy. So the logic here, and this is a good teaching for the younger colleagues who are following this, is that you need to exclude the possibility of regularizing the cornea and assessing the vision as such. And the best way to do this is with a gas permeable contact lens, and that's what we did yesterday, and we were able to reach the 20/25 level with an RGP lens. So this means that we will offer to our patient the possibility of doing a topography-guided reshaping of this corneal irregularity that will also remove part of the scar with mitomycin C and be able to target a vision of 2025, 2020 maybe. And I'd like to hear someone's argument that a 2025 or 2020 patient under this work with what we have been known to do globally, fixing problems mainly from refractive surgery and some from contact lens use, is superior to having a cornea transplant in this young patient. So again, some pearls and some teachings from using all our cornea diagnostics and all the armamentarium that we have, again, always for the benefit of our patient and not jumping directly to procedures. Also, the standard of care for acanthamoeba infection is a double treatment because we know that the cysts are resilient, and why not use 2 agents that are proven to be far more effective in killing acanthamoeba cysts within the cornea than using one because one had success in 1 or 2 cases with that. Hope you found this presentation not scary, but in a way didactic. My heart aches because if we had gone by the book from day one, I think we would have had a better outcome. We would have had much less scarring, a clear cornea within a few weeks, and then prompt corticosteroid treatment once with a confocal microscopy. We had confirmation that there were no cysts in the cornea, and probably wouldn't have to be talking about all these measures. But again, I offer an alternative pathway to avoid a cornea transplant. This comes from a cornea transplant surgeon with at least 3,000 cornea transplants under my belt. This is John Kanellopoulos from Athens. Thanks so much for your attention.